Okay, so thank you very much, Chairman ARC and the entire team for this opportunity. I heard with interest Dr. Gulati's comments, so I will answer those later. Now, I have a lot of experience with this because I was associated with a lot of AIDS patients in AIDS Control Society of Andhra Pradesh. First thing to understand is it is a virostatic drug, ganciclovir or valganciclovir. So it does not eradicate the virus. We have to continue treatment till the patient's immune system can take over. Now, what are the advantages of intraocular ganciclovir? It provides a higher and targeted concentration of the drug so that it arrests the activity almost immediately, preventing progression. And hence the treatment duration with intraocular ganciclovir is only 2 months, whereas it is around 4.5 months with systemic treatment. And the disease-free time also lengthens with intraocular ganciclovir, and treatment failure is rare. So what would be the indications of intraocular ganciclovir, keeping in mind those advantages? One is where there is macula threatening, zone 1 retinitis, or when you need to operate for retinal detachment and you need to clear the retinitis urgently, extensive retinitis, very low CD4 counts, and suspected ganciclovir resistance, interestingly. It has been found that intraocular ganciclovir is effective even in cases where there is suspected resistance to ganciclovir, and healing is observed within 2 weeks to 4 weeks in all cases with intraocular ganciclovir, not systemic Valgan. Now, this is a patient with macula threatening retinitis, recent patient, and we put him on oral Valgan to avoid injections, but it was worsening rapidly, and there was a suspicion of resistance as well in this case as per the ID physician. So we then added intraocular ganciclovir, and you can see the rapid resolution, following which we kept him on oral valganciclovir. Similarly, these are cases where require surgery. They come with retinal detachment and extensive retinitis, immediate resolution with injection. Lady with retinal detachment, and you see the extensive retinitis. And within a week of injections, you can see the marked resolution of the retinitis, allowing us to operate the next day. And in less than 3 weeks, the patient is doing excellent simply because of the intravitreal injections. Another patient, similar situation, macula threatening as well as extensive inferior retinitis, high risk of RD from the extensive retinitis. We tried oral Valgan, but there was hardly any resolution. So switched to intravitreal, and you can see within a week of switching, the complete resolution. And 4 weeks later, no activity. So now we switched her back to oral Valgan. And within 4 weeks, there was recurrence of activity. You can see there, hemorrhage is starting, etc. But this we were able to tolerate. Now, the treatment is longer with oral valganciclovir or any systemic disease, which allows the disease to progress, leading to extensive involvement. And more extensive involvement increases the risk of retinal breaks and detachment. Also, extensive causes more of immune recovery inflammation and allows macular involvement. But more importantly, when we have subtherapeutic vitreous drug levels, which systemic treatment causes, we have higher chances of creating a ganciclovir resistance, which was not there, relapses in the retinitis, and often treatment failure, which I already showed you. So this is where you have very extensive active disease, and then if you allow the disease to smolder, you have large areas of retina disappearing with retinal breaks and detachments. Similarly, patients on valganciclovir, almost 85% will have relapses during their treatment at an average of about 3 months from starting the treatment, which is not the case with intravitreal therapy. Then the systemic problems with valganciclovir are severe anemia, neutropenia, thrombocytopenia because of bone marrow suppression, which the heart also causes bone marrow suppression, zidovudine. So this drug should not be given with zidovudine, which most patients are already on for the HIV. And both together can cause severe myelosuppression. So it needs weekly monitoring of blood counts. It is contraindicated in pregnancy and with renal function impairment. On the other hand, intraocular ganciclovir suffers from no such systemic adverse effects and can be used with zidovudine. Now, another huge factor which comes into play is the cost. The cost of intravitreal therapy is almost negligible compared to the cost of valganciclovir. What costs per month with intravitreal costs per day with oral valganciclovir, because a single vial costs only about 900 to 1800 rupees, which can be reconstituted and used for up to 4 weeks easily, which is what I have done always with no problems, whereas oral is costly. So what is the benefit of oral valganciclovir? As Dr. Gulati had mentioned, It prevents systemic disease and fellow eye disease in most of the patients. So that is the only one advantage. And the disadvantage of intraocular is injections in children can be difficult and adverse effects of any intravitreal injection. So what can we agree to? Well, actually both have their advantages. So just the fact that we are giving intravitreal ganciclovir does not mean that systemic is not required, and both can go on at the same time. The systemic protecting the fellow eye from disease. And it can also be sequential combined treatment where you give intravitreal till the disease is inactive and then carry on with oral valganciclovir as a maintenance therapy. And then finally, when we see a given patient, none of these things work. What we have to see is what works in that situation, which depends on location, extent of retinitis, severity of retinitis, the status of patient's immune competence, concomitant medications which cause myelosuppression, and affordability. Thank you. And
thanks, Dr. Mallika. That was again
if time permits, I'll also.
Oh, you wanted to show this, right?
Yeah. Sorry.
Yeah. You have something to.
Yeah, I was saying that I would like to answer certain of the certain points which Dr. Gulati had mentioned. She was talking about systemic disease of CMV. That's very true theoretically, but practically, in my experience as well as literature, does not support systemic prophylaxis for CMV unless there is confirmed disease which requires management. So prophylaxis with valganciclovir for preventing extraocular disease is not required even in severely immunosuppressed patients. Now, even if there is a bilateral disease, if both eyes are having a macula threatening uveitis, retinitis, or both are having extensive retinitis which can cause detachment, then both need injections. So very often I give bilateral injections, not the same day maybe, separated, but bilateral, because each eye has to be preserved. So just because it is bilateral, it doesn't mean that valganciclovir will be indicated. It depends on the severity of disease in that eye. If urgent treatment is required, bilateral treatment is required. These are the points that I had in mind.
Srinivas, anything to ask?
Good presentation, madam. I think that was really wonderful from both of you. We all know that the bioavailability of the oral valganciclovir is pretty much good. Penetration is good. Still, do we need to add a little more was my first question. And second thing is, I want to ask the panelists that how oftenly we check that zidovudine is being asked in cases where the oral valganciclovir is being given, because I've seen most of the empirically starting them on oral valganciclovir when the patients are on NRIs, we usually don't check because they go to the government setup and they say that I am on the heart therapy, and usually we don't check their most of the times we don't do it. And how often it is dangerous to not give an oral valganciclovir when the zidovudine is there in their treatment.
Yeah, can I answer the first one at least?
Yeah, sure, ma'am.
So the bioavailability of valganciclovir is only 60% of what it would be for intravenous ganciclovir. So it's not too great. And it is nowhere comparable to intravitreal ganciclovir injection. It is not comparable. So to think that because we are giving oral valgan, what is the advantage of intravitreal? There is no comparison. There is no comparison. I showed you macular retinitis worsening on valgan. In fact, most of the cases that I see, they just don't do good on oral valgan alone. Most of the time, we do have to supplement with intravitreal to at least initially to control the disease with 3 to 4 injections. And then valgan is able to maintain that status. So there is no comparison in the intravitreal concentration. Second was the zidovudine. See, ideally we should.
And your frequency would be thrice a day, once in 3 days?
Frequency, yeah. Initially, the induction dose is set to be once in 3 days for till you find activity resolved. And then after 1 to 2 weeks, you can go to once a week. But now we can use, there is a concept of using higher dose, 6 mg per injection rather than 2 mg. In that case, we can just give once a week, even in the induction phase, injection of 5 or 6 mg, and then shift to 2 mg per week. So once a week, even initially. Then to talk about zidovudine, how many of us asked? See, point is we should not be adding systemic drugs like valganciclovir without having any consultation with the treating physician or seeing the treating drug, because drug interactions are known. So we are not even supposed to actually do that independently, or if we do it, it should be after seeing the patient is already using. And that applies not only to this situation, but any situation. When we write a drug, we have to know what other drugs are going on. We cannot allow duplication or interactions. So that should not happen.
Yeah. Thank
Yes,
you very
Ratina
much.
madam. Ratina madam wanted to.
Yes, yes.
Or,
Has Dr. Mallika been quite clear? Shall we go on to the last topic? I don't think there's any controversy.
No, we give that intravitreal injection. That's quite effective. But continuation of the treatment, like maintenance therapy, we use that oral Valgan secretary.
Yes.